All right. Almost there.
Good evening. We would like to welcome everyone to the Neuroendocrine Tumor Awareness Month webinar, hosted by the American Association of Endocrine Surgeons, AAES, and in partnership with the North American Neuroendocrine Tumor Society, or NANETS. I'm Dr. Stacey Woodruff. I am an endocrine surgeon, and I work at University of Hawaii. I'm one of tonight's moderators.
Hi, and I'm Dr. Sara Oltmann. I am an endocrine surgeon at UT Southwestern, and I'll be our other moderator for tonight's webinar. We've assembled an expert panel to answer all of your questions tonight about neuroendocrine tumors, and the webinar is being recorded and will be made available on the AES Facebook page as well as the AES YouTube channel.
We would like to thank NANETS for providing us with frequently asked questions from their membership. We will also be taking live questions from the audience this evening. You can enter your questions in the comment section directly on the Facebook live stream. Please be aware that we will not be answering any personal medical questions or providing specific medical advice. For those types of questions or requests, please seek advice from your doctor and medical team.
We'll start by introducing our expert panel. We have Dr. Tobias Elsey. He's an associate professor of endocrinology at the University of Michigan Health. We have Dr. Bassam Sonbol, who is an assistant professor of medicine at Mayo Clinic School of Medicine and a consultant at the Mayo Clinic Cancer Center in Phoenix, Arizona. He's a medical oncologist specializing in gastrointestinal cancer with a focus on neuroendocrine tumors. And he currently leads the neuroendocrine tumor efforts in the Mayo Clinic, Arizona. We also have Dr. Xavier Keutgen, who is an associate professor of surgery at the University of Chicago. He's an endocrine and neuroendocrine surgeon and is the director of the University of Chicago's Medical Endocrine Tumor Center. He is the co-director of the Von Hippel-Lindau Clinical Care Center as well. We also have Dr. Marybeth Hughes, who is the Division Chief of Surgical Oncology at Eastern Virginia Medical School. She is a professor of surgical oncology and specializes in neuroendocrine tumors. Finally, we have Ms. Lisa Yen, who is a caregiver and patient advocate for neuroendocrine tumors. She works as a director of programs and outreach for the Los Angeles Carcinoid Neuroendocrine Tumor Society, or LACNETS. She joins us to highlight the patient caregiver perspectives.
So we'll start off with Dr. Elsa. What is a neuroendocrine tumor, or NET, and how should patients describe it to their family and friends?
Yeah, this is an important question. I would say most of my patients, when I first encounter them and they just got this diagnosis of a neuroendocrine tumor, they don't really know what this is, where this comes from, right? And when you're diagnosed with any other cancer, it's like, for example, thyroid cancer comes from the thyroid cells, or breast cancer from the breast cells, colon cancer from the lining from the colon. This neuroendocrine tumors are something different, right? So they don't have a particular organ of origin per se. They actually can originate basically anywhere. The typical areas are the lung or the GI tract, or also the pancreas organ. And they originate from these neuroendocrine cells, which are cells that in a lot of organs, such as the lung or the gut, are kind of interspersed there, and they kind of modulate and communicate with other cells around them and modulate their function. And probably the best way to understand what neuroendocrine tumor cells in general usually do, so those cells where these tumors come from, is from the endocrine pancreas, right? So the endocrine pancreas has very important functions. The pancreas is kind of two organs in one. It makes the pancreatic juices for digestion, but it's also an endocrine organ making hormones such as insulin, right? And some of those neuroendocrine tumors in the pancreas, for example, can make insulin as well. And that comes with certain hormonal syndromes. Patients will have too much insulin around and might suffer from low blood sugars. But neuroendocrine tumors, like I said, they can actually originate anywhere. Other typical organs are the small bowel, where it's often associated with carcinoid syndrome because they produce also certain substances which lead to diarrhea, flushing, and some other manifestations. Or for example, in the lung, where they also can lead to constriction, narrowing of the breathing ways, the bronchi, and can lead to asthma-like symptoms, right? So in summary, they are actually originating those neuroendocrine tumors from neuroendocrine cells, which are usually interspersed in a lot of organs. And we would then differentiate them clinically by the organ where this neuroendocrine tumor started, right? So we would actually call it a pancreatic neuroendocrine tumor or a lung neuroendocrine tumor. Sometimes also interchangeably, the term carcinoid is used, which is really an old term. But it's actually an important term because carcinoid basically says that under the microscope, it looks like very much like a cancer, yet they don't have really this classical cancerous behavior as we see it with a lot of other cancers, right? And I think that's another important point, which I always mention. If you, for example, look at the gastrointestinal tract, when we think about cancers and how common they are, we think in two terms, which is incidence, meaning how many patients are diagnosed per year with a certain disease. Or, for example, the other term, prevalence, is how many people are at a certain point alive with a certain disease, right? And they are actually, after colon cancer, the most prevalent cancers. That also tells you that patients with neuroendocrine tumors usually do much better than other tumors, although that is something which I always, in this first discussion, where I also described this, point out is something that is important for us to learn about the next 1 or 2 years, what the course of the disease will be and what the necessity for a treatment is. That's how I would summarize that.
Thank you very much. Dr. Sonbol, can you go into a little bit of detail about what are the important things patients need to know about their neuroendocrine tumor?
Yeah, I think that's a great question. I think one of the main things I tell patients is, I mean, as Dr. Elson mentioned, that these tumors arise from any part of the body. So the first question we ask is, where is it coming from? A lot of times we can really find out where it's coming from, but there are some times where we don't know where it's coming from. So location is key because treatment overall and the management there are similarities, but there are some differences depending where it's coming from. And then the second thing I tell patients is one of the main things I ask myself when I meet a patient with neuroendocrine tumors. I always tell patients that I ask the pathologist, how do the cells look like under the microscope? Do these cancer cells look like the normal cells in the body in terms of the shape? That's what we call well-differentiated neuroendocrine tumors, or they look ugly, large, or small, aggressive. That's what we call poorly differentiated neuroendocrine tumors. So the well-differentiated ones are well-behaved ones, and then the poorly differentiated ones are poorly behaved ones. And then under the microscope, we also tell them, we ask the pathologist, can you do some coloring? We call it Ki-67 stain, and count to us how many of those cancer cells are aggressive under the microscope. And based on that, they can give us a score that goes from 0 to 100%. And based on that, we can assign a grade 1, 2, or 3. So I always tell patients, you can imagine that there is a spectrum that starts from a grade 1 well-differentiated neuroendocrine tumors, end up with a grade 2, and then grade 3, and then ends up with the highest grade is grade 3, poorly differentiated neuroendocrine. We start calling it carcinoma at that time. So that distinction is important because also the management across the spectrum is different. The other thing we also discuss is the stage. So we've learned there's something called the grade, which is under the microscope, and then there's the stage, which the question is, has this cancer metastasized or left the original place, which, for example, let's say it came from the pancreas. Has it left the pancreas and gone somewhere else, such as liver, bone, or something else like that or not? And usually we determine that with scans. So that gives us this stage. Is it 1, 2, 3, or 4? When it has already spread, that's what we call a stage 4 cancer. And then the last thing I think it's important as well to remember that, as Dr. Elson mentioned, I mean, a lot of these neuroendocrine tumors, they have the endocrine capacity. So they have the capacity and the ability to produce hormones. So there is what we call functioning neuroendocrine tumors and non-functioning neuroendocrine tumors. because a lot of these some neuroendocrine tumors, they produce hormones that can be problematic to patients. Like we hear with the small bowel neuroendocrine tumors, with the serotonin causing the diarrhea and carcinoid heart disease and things like that. And then we hear also like with the pancreas, for example, some of them produce insulin or glucagon and kind of disrupt the whole blood glucose and blood sugar in the body. So I think those are the main points. So really the grade and the differentiation. So how do the cells look under the microscope? Is it functioning or not? And the stage, has it spread or not? I think, and where it's coming from, those main things are very important to know.
Great, thank you. Dr. Keutgen, how are neuroendocrine tumors diagnosed?
Okay, so that's a great question. Well, a lot of the time they are not diagnosed for quite some time, unfortunately, because they're a little bit of a zebra. So like we said before, there are neuroendocrine tumors that are functioning, so that they are producing hormone that produce symptoms. A good example, for example, would be a small bowel neuroendocrine tumor that's producing serotonin. You could have symptoms like diarrhea, flushing, wheezing. So those are symptoms that are often pretty general and often are overlooked for quite some time until patients actually get diagnosed with a neuroendocrine tumor. So, obviously a lot of people can have diarrhea or GI problems. So it may take a lot of time for the primary care physician or the GI physicians to realize that this is a neuroendocrine tumor. Hence, it's important to do this webinar because I think it just raises the whole neuroendocrine tumor topic to our patients as well as to providers or physicians that are watching this as well. But so that's one way how a NET could be diagnosed. There are some neuroendocrine tumors that cause symptoms. Again, it's probably not the majority, but for example, again, if you have a small bowel neuroendocrine tumor that's large enough, so it causes an obstruction or a blockage of your small intestine, or it causes bleeding, so you would have blood in your stool or dark stools, those are sort of things that can also happen. They can happen with a lot of tumors, but they can also happen with neuroendocrine tumors. I said it's not that common because these are slow-growing tumors generally, at least a well-differentiated one. And so most patients don't have these symptoms, but that's definitely something that can happen. And then I would say if I look at our practice, for example, in our patient population, we see a lot of tumors that are already talking about stage at a further stage, just because a lot of these symptoms, or I should say a lot of these patients don't have any symptoms. And so it's hard to diagnose them. And they're sort of what we call incidental diagnosis. So, you have a car accident, you get a CT scan, and they see lesions in your liver, it gets biopsied, and then it's diagnosed as well-differentiated neuroendocrine tumors, and you never really had any specific symptoms. So once the diagnosis is made, and usually it's made through a biopsy or through sometimes a special like PET scan called the dotatate PET scan, which is highly sensitive for neuroendocrine tumors. But once the diagnosis is made, then we talk about the staging, like we briefly mentioned before, to try to understand, is the tumor localized and can it be removed surgically, or is it further spread beyond just where it started? And for that, there's a whole bunch of therapies, which I'm sure we'll talk about later. But I think the general concept on how neuroendocrine tumors are diagnosed comes through many, many different ways. Again, incidentally, because you get a scan for something else, because you have symptoms that are either due to hormone production or symptoms that are due to a blockage or the tumor causing some problems locally that would cause you to have pain or weight loss, etc.
Thank you very much. Dr. Hughes, Can you please explain what a multidisciplinary team is and how the team communicates about a patient's care? What happens in tumor board, and can patients attend these tumor board discussions?
Yeah, so multidisciplinary tumor boards are very important. Basically, it is a group of physicians that are familiar with the disease process, and they are usually surgeons, medical oncologists, radiation oncologists, radiologists, pathologists, and they really visit the facets of all the patient care. The benefits of that are that you have the advantage of multiple opinions. Classically, we don't have patients participate in that because we talk about multiple patients, and because of privacy issues and things like that, you can't hear about other people and their issues. And that way, physicians can speak freely and dialogue back and forth about ideas. If there's no set right answer for a patient, they can talk about multiple different options and weigh the pros and cons of all of them and come up with a consensus. But in general, it's important because it allows everybody to look at the entire case, review the pathology, make sure you understand the grade, whether it's high grade or low grade, and acting, you know, like a slow growing tumor or a super aggressive cancer. And so it allows everybody to weigh in on what they think is the best way to treat a patient. I think the other piece that's important is when you're selecting surgeons, and this is partly the American Association of Endocrine Surgeons has a large population of very qualified surgeons that have a lot of knowledge about neuroendocrine tumors. And so I think it's important when you go to a specialist for a neuroendocrine tumor that you make sure that they have some basic knowledge, because there's not thousands of us that do this, but there are enough across the country that you can get really good care in both states.
Thank you. Ms. Yin, how will having a neuroendocrine tumor affect a patient's life? And will they be able to work, travel, exercise, and do the other things they enjoy doing?
Thanks for asking this question, Dr. Woodruff. As a caregiver myself, I can say that neuroendocrine tumor not only affects a patient's life, it also affects the lives of their loved ones. How it affects someone's life really depends on so many factors, all the things that Dr. Elsie, Dr. Sonbol, and Dr. Keutgen described so well. What type of neuroendocrine tumor, grade, if the tumors produce hormones, how much disease there is, where the disease is, what symptoms people experience, type of treatments, et cetera. But those are just the medical factors. That doesn't even mention the stress, anxiety, depression, and trauma people experience. And all those things affect one's capacity. So my husband and I like to think of it like a bank account. And there's things like stress or side effects of treatments that make withdrawals. And there's things like support and education that might make deposits. And we're definitely much more aware now of our bank accounts than we were before diagnosis. And there's ups and downs and different seasons where one's capacity might be less than it was before. And for my husband and I, his diagnosis, surgery, and treatments, they completely disrupted both of our lives and our ability to work and travel for at least the first couple of years. But not everyone has that kind of experience. One thing I can say for sure is that we make different choices now since his diagnosis. And that's because our priorities are different. And when I say that things are not the same, in many ways, it's not all bad. For example, we savor the things we enjoy much more now. We find joy and beauty in even the small things. And I can't say there's one universal answer to this question of how NET affects one's life, other than it often changes our outlook on life. And even if and when people return to doing some of the same things like work, exercise, the things we enjoy, we're in the process of learning to find a new normal. We might have to plot out bathrooms on a road trip or take more breaks or plan around monthly shots, but it is possible to find a new normal.
Thank you, Lisa, for those additional insightful commentary. I know that's a lot of what our audience is wanting to hear. Dr. Sonbol, can you talk a little bit about carcinoid syndrome and carcinoid crisis? How is this treated?
So carcinoid syndrome, I mean, in general, the term carcinoid in general, it's an older term. Really, when these tumors first described, they thought they're not really cancerous, so they call them canceroids or carcinoids, so like cancer. And then later on, we learned that they are actually malignant and they have the malignant potential, so they are cancerous. So we're trying to avoid the term carcinoid in general as tumors, but there are some things that are still used, such as the carcinoid syndrome and carcinoid crisis. So as Dr. Elsa mentioned before, these tumors can produce hormones, and when these hormones are produced, there is what we call carcinoid syndrome. And carcinoid syndrome can manifest with multiple types of symptoms that can be depending on, most commonly, it's really coming from when the tumors are coming from the small bowels. And it can happen also in lung neuroendocrine tumors or lung carcinoid. So for example, in small bowel neuroendocrine tumors, we see with the carcinoid syndrome, the symptom the patient described as a flushing, which is different from the hot flashes. The hot flashes is more what we call subjective, meaning the patient would feel it. The flushing, it's objective, that even someone else can see it or the patient can see it in the mirror. It's mostly on the chest and on the face it can happen. And then also as a manifestation of that, we see loose stool and a frequent stool or diarrhea as a manifestation of carcinoid syndrome as well in patients. The more severe form of carcinoid syndrome is sometimes when these tumors they produce a lot of hormones. If any manipulation can be done on the tumor, most commonly with a surgery, for example, intervention on the tumors, and these tumors produce serotonin. Sometimes when you intervene on these tumors, there is a flush of serotonin happening in the body. So a lot of these hormones just get released in the body, in the bloodstream, and that can lead to really dangerous fluctuation of blood pressure and the hemodynamic status of the patient. And that's what we refer to carcinoid crisis. And I just want to mention that carcinoid crisis is very rare. One of the reasons why it's rare is because the surgeons and all of us in the neuroendocrine community are very aware of it and how to prevent it. Like a lot of times when my colleagues in surgery, they see a patient and they want to operate and they feel that the patient is a high risk, they ask me to start the patient on whether long-acting sandostatin or lanreotide beforehand, and then they have the drip of octreotide ready if needed. So someone might argue that it's actually rare because we're more aware of it and we are preventing it. So that's what we refer to our carcinoid crisis. The last thing is that something you didn't ask about, but I want to also cover it, which is the carcinoid heart disease, because patients also is something that's important and being recognized, and it's very, very important because it's underdiagnosed still, meaning that a lot of patients with neuroendocrine tumors are walking around and have carcinoid heart disease without knowing. Carcinoid heart disease is what happens is those neuroendocrine tumors, again, most commonly the small bowel ones, they can produce serotonin, and that on the long run can lead to further disruption and destruction of the heart valves, most commonly the right heart valves, the tricuspid and the pulmonary valves, and that can lead to what we call carcinoid heart disease. So the early recognition of these things in general is key in managing any of those things.
Thank you, Dr. Sonbol. Dr. Elsa, is neuroendocrine tumor genetic? Do patients need genetic testing? And what about their family members? Should they have testing or screening?
So that's, of course, an important question, and a question very dear to my heart. Although I'm an endocrinologist by training, a lot of my life is actually in cancer genetics. I staff a cancer genetics clinic as well. So when it comes to the evaluation for genetic contribution, basically something somebody is born with that gave them a higher risk to develop these neuroendocrine tumors, it's again very important to see where these tumors are arising. And it particularly important genetic considerations for patients where the tumor is actually arising somewhere in what we call the foregut, which actually includes the lung, the pancreas, as well as the duodenum and the stomach. And the classical carcinoid is usually somewhere behind that in the midgut small bowel. And there's really nothing known about hereditary predisposition to carcinoid in the small bowel. There are some suggestive findings, but nothing we would actually clinically test for. So the majority of considerations is actually for patients that have either stomach or pancreatic or duodenal carcinoids. And again, it's important to see what hormones do they produce. So for example, gastrinomas, patients that have an oversecretion of gastrin, which leads to very high stomach acidity as well as ulcers, those patients probably have a higher chance to actually have some genetic predisposition for this. And the same is probably true for pancreatic neuroendocrine tumors. In the main syndromes we consider here are probably multiple endocrine neoplasia type 1 and Van Hippel-Lindau disease. So multiple endocrine neoplasia type 1 is actually a syndrome which comes with tumors of the pituitary, a small gland that is on the bottom of the brain, as well as hyperparathyroidism. Those are glands that regulate calcium levels in the blood, and pancreatic neuroendocrine tumors, as well as sometimes neuroendocrine tumors of the lung and the duodenum as well. However, for multiple endocrine neoplasia type 1, I think it's always important to understand that usually these patients will have some other manifestations prior to having symptoms or a diagnosis of a neuroendocrine tumor. So I can tell you that I have never diagnosed a patient in my professional life based on the occurrence of a neuroendocrine tumor with multiple endocrine neoplasia type 1, particularly the high function of the parathyroids and the high calcium levels precedes the diagnosis. And patients will have a strong family history of either of these manifestations. Basically, the same thing is true for Van Hippel-Lindau disease, which comes with manifestations of the brain with hemangioblastomas, which are blood vessel tumors, kidney cancers, as well as pancreatic neuroendocrine tumors, and also pheochromocytomas in the adrenal gland. Usually other manifestations precede the diagnosis of neuroendocrine tumors. That's why, in general, I'm convinced that a genetic evaluation with a full family history and a full personal history, which is really the key to the diagnosis of what we do and ultimately decide for genetic testing, is valuable for everyone. However, a general diagnosis of a neuroendocrine tumor probably has a fairly low outcome in terms of genetic testing. Yet it's important for example, one related tumor, which is often mentioned together with neuroendocrine tumors, and those are the pheochromocytomas and paragangliomas, which are tumors of the adrenal gland or related tumors elsewhere. Those have a very, very high genetic component, and about 1 in 3 people with that diagnosis will have an underlying genetic change that gave them a higher risk for this. There's also another emerging field where it's highly important to know whether a patient actually has an underlying genetic syndrome, such as highlighted with Van Hippel-Lindau disease. There was just a recent study testing a new in-class drug specific for Van Hippel-Lindau disease-associated tumors, and pancreatic neuroendocrine tumors in these patients almost responded through the board with that drug with very little side effects. So that just tells us that the genetic makeup of the tumor and also the genetic makeup of the patient with the risk increase to develop these tumors is highly important and will become even more important in the future in terms of therapy of these tumors. Last thing I would like to say is that in case a genetic syndrome is diagnosed, it's of course highly important for the family because every first-degree relative will have a 50% chance to carry the same genetic change and will be at risk for those tumors as well. And that actually gives us the opportunity to start surveillance in these patients very early on and hopefully catch the tumors at a stage where the multiple endocrine surgeons and other surgeons on this panel can take care of these tumors before it comes to the point where they actually metastasize and are not curable. Yeah, family testing is probably, but family testing is really something that should only come after the initial testing of what we call probe and the initial patient. And then we kind of walk our way through the family.
Thank you, Dr. Elsa. Dr. Keutgen, how do you determine where the tumor comes from, and how does this guide your treatment decisions? How important is it for us to find the primary site of the tumor, and what happens if we don't know where the tumor is coming from or the site of origin is unclear?
Sure. So again, it comes back to the diagnosis of these tumors, right? So again, with regular CT scans, MRIs, you can figure out whether there is a mass or not. And like I said, you can either biopsy it or get a dotated PET CT if it's in an area where you can't biopsy it and see if it's a neuroendocrine tumor. But occasionally we do have patients that have what's called unknown primary tumor in the setting of metastatic disease. So, you know, occasionally we see patients that are convinced they have a neuroendocrine tumor, but they have no evidence on scans that there's a neuroendocrine tumor. So, you know, those are the hardest cases because, you know, like we said, neuroendocrine tumors can secrete hormones that sometimes we can't even measure because we don't know exactly what they are, and all kinds of symptoms can come up. But generally, if a neuroendocrine tumor produces symptoms related to hormones, it will show up somewhere. It may not show up as a primary tumor, but it will show up usually as metastatic disease. So let's say you have, you know, disease in the liver where the tumors don't come from, they come from somewhere else and go to the liver. You have a biopsy, you know, it's a neuroendocrine tumor. You know, those are sort of the tumors that you know, may or may not have a primary tumor that is detectable on a scan. So when we talk about unknown primary tumors, we usually talk about unknown primary tumors in the setting of metastatic disease. So we don't talk about unknown primary tumor where you scan and there's just nothing there. You know, you have your endoscopies, you have your colonoscopies, you got your PET scan, you got your CT scan, you got your MRIs, and there's just nothing there. You probably don't have a neuroendocrine tumor. Even if your biochemical workup, your chromogranin A, for example, is positive, and there's a reason why I didn't mention it last time as diagnosis, because chromogranin A is a reliably unreliable marker that is not helpful for diagnosing neuroendocrine tumors at baseline. Sometimes to follow up these like tumors, yes, but not to diagnose. You know, again, if there's nothing there, you probably don't have a neuroendocrine tumor. If you have metastatic disease, or you have, let's say, a mass in your small bowel mesentery, the area that supplies your small bowel, it's quite common actually that, especially for small bowel neuroendocrine tumors, we don't see the primary tumor on the scan. That doesn't mean it's not there. It just means that it's usually too small to be actually detected on a dotatate PET CT or on a CT scan. So I think that if you know enough about these neuroendocrine tumors and you know the pattern on how they tend to spread, especially to lymph nodes, you can actually get a pretty good idea of where the primary tumor is. I'll give you an example. If you have a lymph node mass or mass that you think are basically enlarged lymph nodes along the vessels that supply the distal part of your small bowel, they're called the ileocolic vessels, but you have had a scan that doesn't show anything else, most likely the primary tumor is in the small bowel, in the distal small bowel next to the right colon. And then when you take them to the operating room, that's what you're going to see. It's important to understand the disease process, to understand how and where these tumors tend to spread. And then usually just looking at regular scans, you can get an idea, or the dotatate PET scan, you can get an idea where the tumor is, even if it doesn't light up. Also important as surgeons to know when you go in that you have to run the entire small bowel, you know, because some of these tumors can have about 30%, for example, for small bowel neuroendocrine tumors have multiple sites, not just one site. So you may find one site, you're all happy, you take it out, but then you didn't run the rest of the small bowel. And so you have unknown second primary tumors that you haven't found, right? So I think, like Marybeth said before, I think going to experienced surgeons that know what they're looking for is really important. To your last question, does it matter whether you see or know where the primary tumor is? It does matter if the disease is localized, you're doing an operation and you're trying to cure the patient. Ideally, in those cases, you really want to take the primary tumor out. So again, you got to run the bowel, if it's a gastrinoma, you got to palpate the duodenum. If it's in the tail of the pancreas, you may want to do an EUS pre-op or use ultrasound in the OR. There's many things that we can do as surgeons pre-op or during the surgery to try to figure that out. Does it matter if you have metastatic disease? Less so. And I certainly have a handful of patients where, they've had liver lesions. We've taken them to the OR, we've taken out the liver lesions, and we run the bowel, we did the ultrasound of the pancreas, we palpated the duodenum, we looked everywhere, and there's just no primary tumor to be found. I mean, there are these exceptional cases where this is the case. When you have metastatic disease, the cat's out of the bag in the sense that even if you operate, the recurrence rate is very high in the liver. So it doesn't mean you can't live very long. It doesn't mean there are not great therapies to treat you. But in those situations, I think that if you really can't find the primary tumor in your experience and you have looked where you need to look, it's not the end of the world. You just basically do what you can surgically to remove the metastatic disease if it is resectable, and then you just continue to surveil the patients. And maybe the primary tumor will show up at some point, and then you can take care of it, or maybe it won't. I mean, I have a patient where I did a right liver lobectomy 6 or 7 years ago, and that was it. It never showed back up. We just don't know where the primary tumor is. Side note, there are certain stainings nowadays on pathology. There's also molecular genetics of the tumor that can give you a hint of where the primary tumor is. There's certain mutations, ATRX, DAX, MEN1, that are very typical with PNETs, like with pancreatic neuroendocrine tumors. Certain stainings like CD2 that are also very typical for small bowel or GI neuroendocrine tumors. So if you work together with your pathologist, you could certainly get an idea even before you take somebody to the OR by using some of that biopsy samples to kind of give you an idea. So it's a long answer I gave, but I hope it was somewhat clear.
Yes, thank you very much for that helpful information. Dr. Hughes, how do you determine if a patient is a surgical candidate, and what is the best surgical approach? And what are the other possible treatment options?
That's a great question. I think that's probably one of the most important things we do as endocrine surgeons is when we have a patient and we look at a couple different things. So where is their tumor? What type of neuroendocrine tumor are we dealing with? And what operation would be required? And then we look at their fitness. So it has to do with your medical conditions. It has to do with whether you have cardiac disease or lung disease or things like that. You have to be kind of medically fit to be able to tolerate an operation, because we don't want to hurt you with an operation. We want to help you. So that's very important. And so we look at all those factors. So if it's a pancreatic neuroendocrine tumor, for example, it matters the location in the pancreas. So if it's on the pancreas and doesn't involve that main pancreatic duct, then sometimes you can do what's called a nucleation, which is kind of just taking out the tumor with a little rim of normal pancreas, which is a little bit different than other kind of pancreas tumors. And then if it does involve that main pancreatic duct, then you have to do a formal resection of the pancreas. If you're at the tail of the pancreas, that involves, cutting in front of it where it's this negative edge and taking the downstream part that heads toward the spleen. If it's in the head of the pancreas, which is over by the small intestine duodenum, then often that will require a pancreatic duodenectomy or a Whipple procedure, which is a little bit more extensive. If it's a small intestine neuroendocrine tumor, then that requires an intestinal resection. For small intestines, we always try to preserve the ileocecal valve if possible, just because that's the little valve that lets all the liquid from the small intestine go into the colon. Sometimes it's not possible because of where it's located or where it's gone to lymph nodes along those blood vessels. Sometimes you have to take that out and put the intestines back together. How we do those operations varies. But what I mean by that is sometimes we do laparoscopic assisted cases where we can do a small intestine operation, but we always, like Dr. Keutgen told us, that we like to run the small bowel, which is you want to feel the small bowel to make sure you're not missing any of the smaller neuroendocrine tumors that may be there if they're multiple. So about 30% or a third of cases, they can be multiple, and you really don't want to miss those because then they'll just represent later with issues. There are also circumstances where if the tumor is already spread from what we call the primary site to the lymph nodes and to the liver, there are times when we will operate on metastatic disease and do what we call surgical cytoreduction or debulking. You'll hear those terms, where if you can get out the vast majority of the tumor, so there's data between 75% and 90%. I tend to be on the 75% with the newer data. But if you can get 75% of the metastatic tumor out and your primary out, then the patients seem to derive both survival and progression benefit. But not everybody is aggressive like that, so that's why you have to get a surgeon who has that experience. And sometimes tumors widespread and in bones and things like that, and sometimes surgical resection doesn't make sense. If it's a not functioning tumor where it's not making hormones, it's not making people symptomatic from that, there are other ways to treat like let's say there's a lot of burden in the liver, there are interventional radiology procedures that can allow you to decrease the amount of tumor in the liver without undergoing an operation by a surgeon. So some of those are what we call bland embolization, where they kind of go up into the arteries feeding the tumors, because the neuroendocrine tumors are very bright on what we call arterial phase, because they take up a lot of the arterial blood flow as opposed to the portal blood flow like normal liver. And so you can target them by going up into the hepatic artery and kind of choking off their blood supply. And that really helps a lot with the tumor volume. And often if it's functional, that helps with that as well. If you're secreting these hormones, it can decrease the amount that goes right into the bloodstream and makes you have symptoms. There are other types of embolizations, such as radioembolization, where they put little radiation pellets up through the hepatic artery as well. And then there, of course, are other treatments like Lutathera or PRRT that you'll hear about, which that kind of goes everywhere in the body. And that's a radio-labeled little radiation marker, but you have to have serotonin 2 receptors, which you would know if your tumor was bright on a dotatate PET scan, that would be something you may be a candidate for, but there are side effects and you have to have good kidney function and things like that. So there's kind of a lot that goes into all these different treatments. I hope that answers most of the questions, but there's different approaches, both surgically, laparoscopic, robotic, open operations. And then, of course, there's the multidisciplinary team with the interventional radiologists. Sometimes if you have a single site of focus in the liver, you can just do an ablation, and that can be done percutaneously. Of course, it can be done operatively as well.
Thank you, Dr. Hughes. I think your answer really highlights the value of the multidisciplinary team, both with ensuring that every team member knows their role, and then also all the coordination of that care across the different specialties, both for timing and sequencing and ensuring everybody knows the next step to come. Ms. Yen, if we can direct a question now to you, what can caregivers and patients do to help prepare for both the surgery itself as well as the post-op phase?
Yeah, thank you for this question, Dr. Oltmann. This is a very good question and a question that comes up often in our support groups. In fact, we released a blog article a couple months ago with practical tips from those in our LACNETS community after some very lively discussions based on firsthand patient and caregiver experiences. We know, of course, that the surgeon will explain the surgery and explain it very well, as Dr. Hughes just did. And I'm also curious what our esteemed surgeons on the panel think about this question. I'm just going to share a few tips from our patient community. And of course, these tips do not replace the instructions given by the medical team. And I would talk to your doctor about your own individual care. So in terms of before surgery, my husband was given this specific charge from his surgeon. The surgeon told my husband that his job was to get as strong as possible. And Dr. Hughes mentioned being medically fit. So for my husband, this meant getting stronger by walking, being physically active, and eating a balanced diet of nutritious foods. It was not the time to start dieting or suddenly become vegan. Not that there's anything wrong with plant-based diet, but not the time to start making very drastic changes. And it's important to be honest with your medical team and tell them all the medications, supplements, vitamins, and complementary treatments that you're taking. In terms of preparing for the recovery in the hospital, it's important to ask about pain management. Who's going to be managing the pain after surgery? And when will that relationship begin? Is there a pain management team involved in the care? Also, having someone present who can take notes, ask questions, and advocate for you if you have concerns, issues with managing pain, or difficulty communicating with your medical team. It's very helpful. You're on a lot of drugs, lack of sleep, pain, stress. There's a lot of things that's clouding communication and judgment. So it's helpful to have someone there. And another thing is really to think about setting up a healing environment. So the doctors, the nurses, the staff, they're taking care of all the medical things, but also consider preparing a music playlist with maybe healing music, and download or practice some mindfulness meditations, breathing exercises, or visualization exercises. They can all help with healing. And then in terms of preparing for your return home, we like to consider your mobility, pain, and the symptoms you might experience, and prepare your home for the things you need to have on hand to really conserve your energy and prioritize your recovery. So you can really focus on your recovery and not have to worry about a million other things. So this means preparing a list and schedule of your caregivers, maybe finding out what diet you'll be on after surgery so you can buy the appropriate foods or prepare meals before you go into surgery, or tell your friends and families who might be preparing your meals what kind of diet you need to be on. I like to stock up my medication cabinet with over-the-counter medications you might need after surgery, or even in the long run, like acetaminophen or Tylenol, stool softeners, and laxatives. That way you don't have to make a sudden run to a pharmacy. And then plan on a system to call for help for your family or friends or caregivers that might be in the house with you, because sometimes our house can be very big, and it's helpful not to have to get up and down. So you might want to have a handbell or flick buttons to be able to call someone. And then last but not least, it's helpful to set realistic expectations. We like to all push ourselves and do a lot of things, but this is a time to take it slow, to listen to our bodies, to know there's no rush. You're going to have good days and bad days. And patients often say it takes a lot longer than expected to recover. You don't get gold stars if you do it faster than someone else. And there's no need to compare to how someone else recovered. This is all about you. And it may take a lot more time than you expect to feel like you're back to what is your normal. So it's important to give yourself grace.
So much, Ms. Yen, for those helpful tips and insights. We have one last question for you. What do you think are the unmet needs of patients with neuroendocrine tumor and their caregivers?
Wow, this is such a big question. We all recognize that access is a big issue, access to providers who really understand NET and access to treatments, including clinical trials. There's financial gaps, of course, including cost of medications, treatments, travels to see specialists or doctors. And one important unmet need is in reaching underserved communities. We know that there are racial disparities in diagnosing and treating patients, and we need to do better increasing diversity in clinical trial enrollment as well. It'll take us all working together to try to bridge these gaps in care in order to reach all people affected by NETs. In terms of educational needs, I would say personally, high-grade lung NETs, carcinoid heart disease, the rare NETs like pheopera and adrenocortical cancers. And I would say there's a gap in terms of patients knowing what available clinical trials there are specifically for them. There's actually a lot of effort being done in terms of patient education, especially in terms of educating patients about disease and treatments, as we're seeing this week and this month with NET Cancer Day and NET Cancer Awareness Month. I personally believe there needs to be more attention in terms of the psychosocial, emotional, and mental health care as well. Both patients and caregivers are experiencing so much stress, so much grief and loss with a cancer diagnosis. There's loss of identity, of dreams and aspirations, of the life you once knew. And I know that the Medical College of Wisconsin, we heard this from NANETS, the symposium last week, that they have a psychologist who's present in the very first appointment with every NET patient. And this helps to destigmatize and normalize the need for psychological support. And so in my ideal world, every NET patient would see a psychologist, and every NET patient diagnosed with NET would be referred by their doctor to a NET patient and caregiver support group or a NET patient advocacy group.
Thank you, Dr. Yan. I think those are all excellent points and often areas that get overlooked. And those are the ones that really impact a lot of the takeaways that both the patient and their caregivers have, both when they're leaving the doctor's office as well as when they're leaving the hospital system. We're going to transition off of one of the comments that you've made about sort of upcoming clinical trials, and we're going to direct this question to Dr. Sonbol. Can you talk to us a little bit about any areas of clinical trials that are currently available?
Yeah, they're actually really good. There are lots of efforts right now being done. I mean, they have been done on for clinical trials. I usually think of clinical trials aspects in terms of new things being tested or kind of moving things around. So like to give examples with moving things around, like for example, one of the studies that is available in multiple centers over the US is, the standard of care after doing a pancreatic neuroendocrine tumor surgery is to do nothing and just observe the patient and follow with scans. But now one of the studies is asking the question, can we do more? Can we give an oral chemotherapy called capecitabine temozolomide or CAPTEM? And see if that would help patients. So that's a study that's being done because we know that CAPTEM works in metastatic neuroendocrine tumors. So let's try to bring it to the earlier stages of the disease. Same thing like what was mentioned before, that those neuroendocrine tumors, they have on the surface of them, they have, I call them like antennas, you can think of them, or like that we call them receptors, the somatostatin receptors. So a lot of them, they have those receptors and we can target them with multiple therapies. So I think Dr. Hughes already mentioned how we have the PRRT, which is kind of injecting intravenously with a drug that goes all over our body, hook up to those cancer cells on those receptors, and then deliver radiation inside. So for that, we have already an approved drug called lutetium-177 or Lutathera, and that has been approved for a few years now. But it's approved as what we call a second-line therapy, meaning it's a patient already got lanreotide or octreotide, and now it's not working, and now they're going to go to the PRRT. One of the studies is asking the question, can we do lutetium-177 upfront? Meaning now I meet a patient with metastatic disease. Would it be beneficial to start right now with lutetium-177 rather than waiting for later on? And then the other question is, we know that lutetium-177, in kind of more technical aspects, is what we call a beta emitter in terms of the radiation aspects. Now, a lot of the novel agents being developed for PRRT aspects of using what we call alpha emitters, so alpha agents. So newer agents using the same concept of injecting intravenously to target any cancer cells throughout the body, and doing kind of with newer agents. So for example, all these things I mentioned, we have those trials here at Mayo Clinic, Arizona, and they're available in multiple centers with the colleagues on this call, for example. So I think it's important is to always talk to your doctor first to kind of choose what best trial suits you best, because all of these clinical trials, they have what we call inclusion and exclusion criteria. And there are trials that might not be suitable for you or might not suitable for you now. You might have better options that are already studied. So it's always important to discuss with your doctor. And if your doctor is not a neuroendocrine specialist, we all in the neuroendocrine and in the oncology community, we all are comfortable with the concept of second opinion. I think that's one of the things I always tell patients, you're not going to offend anyone if you do a second opinion. If your doctor get offended by a second opinion, then that's not the doctor to choose. So that's why I think it's important to discuss with your doctor those options. And it gets a little bit challenging to know what trials are available. I think it's always important to contact a specific center to ask, because sometimes those things are posted. For example, you pull up the Mayo Clinic website and you see, oh, there is a clinical trial available. But if you ask me today, I tell you, well, actually, we just got an email that it's on hold. So that's why it's always important to reach out before you travel and arrange, a flight and things like that. I think those are, but I'm very optimistic. We've done a lot of, there are a lot of things that have been done in the last 5 years in advancements that really have helped a lot of patients, and things will only get better, hopefully.
I would just like to add, I think that is excellent. And for patients that just want to look themselves, you can always go to www.clinicaltrials.gov, and that lists every clinical trial for everything in the world, basically, that has any federal funding. And so that's almost every trial that you can think of. It may be a little bit too much, but sometimes people want to look at that, and that allows you to see, is a trial open near you, and not have to go to maybe Mayo if that's across the country. So there are options like that may be helpful. They're not 100% like up to date on hold versus closed versus accruing, but they try to keep those current. But that's just something you can do for yourself as well, or your family.
Yeah, if I can add one quick thing, I think this is, there's not only clinical trials as we think of treatment trials, right? So I think the other thing is that there's still a lot of unknown about neuroendocrine tumors, right? In terms of their natural history, what happens to them, and even to see how is it actually treated all over the country. I mean, we all have different approaches to this, right? How well do patients do with this? And there's, for example, one larger study with multiple centers run out of the University of Iowa, the NetPro study, where we approach patients and just simply gather the facts, right? It's like, how were you diagnosed? How were you treated? And I think this is one of the great examples where we really need to partner with patients, physicians, and researchers to really learn more about those diseases. And I just wanted to add this because I think when I think about research clinical trials, it's not all about a therapy, which is, of course, always on our mind first. But I think these other things are very, very important as well. And I think they can also shape a true community between all of us who are involved in neuroendocrine tumors.
Yeah, I'm glad you brought up the quality of life trial. I also wanted to bring up that Josh Mailman, who's the president of NorCal Carcinet, has been working on a patient-friendly clinical trials website where patients can put in their own information and search. And it does link with clinicaltrials.gov. So that is open access and available to patients.
Thank you for the comprehensive answers to that question. So as we approach the top of the hour, we would like to thank our viewers for joining us this evening. A special thank you to our expert panelists for taking time out of their busy schedules to answer your questions and discuss neuroendocrine tumors. We want to thank NANETS again for their partnership.
As a reminder, this session was recorded and will be available on the AAES Facebook page as well as the AAES YouTube channel. For more helpful information for patients, please be sure to visit the AAES Patient Education website. And that link will be posted with the Facebook live stream.